Hi, everybody. My coffee has kicked in. So you're going to say, why are you and Dr. Manoli talking about the guidelines? Because people often say, what do we need to know about treatment guidelines? And why do we even have treatment guidelines? Well, the whole point of having treatment guidelines for rare disease is so that everybody, all the providers around the world, are doing what is cutting edge in terms of therapeutics. Now, I'm getting classical homocystinuria, and Eirini is doing the remethylation defects. And part of the reason I'm doing classical is because I'm the senior author on classical. And what I want you to all think about is, what are the things that you want the providers to provide to you in terms of treatment guidelines? All right. And part of that is we're in the middle of writing the CVS guidelines. And so let me know if there's something that you think that we've missed that we need to address for you all. Okay, so what are we going to try to learn today? We're going to try to recognize the basic recommendations for CBS. We're going to list how do you write guidelines? Like, how do you guys do this and what goes into it? And I want us to use at least one of these things in real life. All right? Whether that is come to your provider and say, the guidelines say this, or you provide me something on the card that you think we need to include in the CBS guidelines, or you provide Eirini something on the card that you think they missed in the remethylation guidelines. Okay? Everybody got it? Okay. So CBS, Dr. Thompson did a great job of talking about CBS deficiency. And all guidelines really start out with, what do we know about how people present? And how do we tell providers what they need to look for? So we really think of the baseline of every guidelines is, what are the things that people present with? And for CBS, it's CNS, eyes, skeleton, vascular system. And so our guidelines have to include all of those things. How do you address those things? Are there therapeutics that are specific for CBS? Are there therapeutics that we don't necessarily always cover? Now, I'm going to do a pathway too, because I'm a biochemical geneticist. We can't get away from pathways, but I want to make it a little simpler, all right? Because the way that I like to think about therapeutics for CBS is we're stuck in a box, all right? Food goes into that box, but we can't get out of that box. So we go round and around and round between homocysteine and methionine. And we do have betaine that can convert homocysteine to methionine, but we're stuck going around in that box, all right? And our big issue is therapeutically, how do I get out of my box? All right? How do I not put too much into my box? So I've got to remember this, 2017, we sat around and we locked a bunch of experts in the room. And that's a list of the experts. And we said, according to the literature and according to what we know that is published, how do you best take care of people with CBS deficiency? All right? And we're going to talk about the 2017 guidelines. But guess what? We are locking everybody in a room again. And so these are the people that are on the current guidelines. Some pictures you may recognize. This is an international collaboration. You'll see some of the folks. I like to point out Danae's right in the middle. Okay. But don't tell her what you want on the guidelines. Tell me. She's really busy. I'll just tell her what you told them. Some of these people were on the original guidelines. Some of those folks might recognize Andrew Morris kind of at the bottom and Victor Kovich, who are basically been landmark researchers for a really long time. All right, how do you write guidelines? Because if Eirini and I are going to talk about guidelines, let's talk about how do you write guidelines. So we gather everything that's published about the topic. Initially, I think we looked at 1,500 papers, and we reviewed about 300. In the revision, we're doing 178 just for CBS deficiency. Eirini, how many papers did you guys have to review? Way too many. Huh? 360? Yep. We got to read all these papers. At least 2 people have to grade it. It's reliability and strength of the paper. How good is the science in the paper? Is it accurate? How did they describe the cohort? And then we got to summarize it because not everybody can read all these papers. And then you sit around and you create recommendations according to what the literature tells you you're supposed to do. If there's no data, you pull the experts. That previous picture is what the experts for the newest CBS guidelines are. The previous slide was the experts that were locked in a room. You got to decide, how strong is this data when you make a recommendation? Is this really good thing? Should everybody do it? Or is it kind of Or is it, we don't have any research here, so we're going to talk about expert opinions? You got to decide how strong the recommendation is. So we're going to poll people and say, how much do you believe this data? And then we're going to distribute the guidelines. So you'll all get copies of the guidelines. That's part of the reason why Eirini's talking. That's part of the reason why HCU Network America tells you a summary of the things. Okay. And so let's talk about the old guidelines for CBS deficiency. I try to make this as interesting as possible. So I basically made it a flow chart. The way that you can look at this flow chart, we're going to start at the top, which is diagnosis, and then we're going to move through this flow chart. The numbers are according to the statement for the recommendation that they go for. So the first part of the flow chart is clinical presentation. We've got lots of data about this. That was statement number 1. And then we kind of move down as we go and we say, okay, pediatrics, what's the most common way to present? And then how do we make recommendations according to how you're supposed to do newborn screen? How are you supposed to do family screening? And so that's the way you work. On the adult side, vascular presentations are the most common for CBS. And so that becomes, statement 2. We move down and we say, okay, what's the best way once you've kind of got people presenting to make the diagnosis? So biochemical testing, we're going to do these biochemical testing. And then how do you do that biochemical testing? Once you kind of do the biochemical testing, you say, okay, is this biochemical testing abnormal? And if the testing is abnormal, you go down a whole different pathway. What are the other things that this could possibly be? But if it is abnormal, you say, okay, we should do DNA testing. And if you don't find a CBS, you go to the non-elevated group. If you find a CBS biallelic variant or even one variant with biochemical findings, you go on and you say, okay, is somebody pyridoxine responsive? Do they have B6? Are they responsive to B6? If they are, how do you do that? How do you figure it out? So what is the best way to do that responsiveness? And then you go yes and no. And then you move on and you say, okay, is this person pyridoxine responsive? If it's yes, you've got one set of recommendations according to what your goals are. If it's no, you've got a different. We're going to stop a second and talk a little bit about what the goals of therapy are. For pyridoxine responsive, the goals of therapy for homocystinuria, or total homocysteine, is less than 50 micromoles per liter. And you're like, why is that the number? Well, because that's the number that we know, 1, we can get to, and 2, that the literature supports that we should try to get to. And then it defines, if you're a partial, you should probably be on B6. But if you're a full responser, you might be able to get away with B6 alone. And so then how much B6 do we do, or pyridoxine, and what are those goals? And if you respond to that, great. Make sure your B12 and folate is replete. This is why some people are on B12 and folate. And then we go to step X. Step X isn't on the next slide. If you don't get to our goal numbers, we better add betaine. We might have to add diet, even if you're a partial responder. Okay, if you're a non-responder, which is on that side, you say, okay, don't use pyridoxine. Pyridoxine has side effects if we don't need to use it and you're not going to respond to it. Let's stop it. So then the first thing, the thing that has the most data to show for therapeutics, is a protein. And this is a protein restriction. There's a big discussion about whether you do protein or methionine restriction. We can talk about what the literature says. Let's just say it's not very clear in the literature which to do. Your goals are a total homocysteine less than 100. Why is it 100? Like, why did that number come out? What's the reason 100 is selected? The reason 100 is selected because that's what the best data says that you get in the first 4 years of life for normal growth and normal intellect. Does that mean it's applicable to everybody? Maybe, maybe not. but we don't have information that helps us make that number lower. Why do we not have information to make that lower? Remember, we have to go back to the literature, go back to the clinical trials, go back to the natural history. And what Dr. Thompson very much highlighted is Dr. Mudd's 1985 paper is still probably one of the best papers for CBS deficiency. Even though we've been gathering information as part of E-HOD, the European Network and Registry for Homocystinurias and Related Disorders, that Eirini will talk about in probably a second. Even though we've been collecting data for 10 years, we don't have anything that's clean enough to say that we can go lower than that. Let's say you get less than 100. We say, yes, great. We're going to make sure your B12 and folate replete. We're going to go to step X. If it's no, it's betaine. You add betaine. And the reason it's this order is because that's what the literature tells us, and that's what we've been historically able to do. All right. I think I just went the wrong way. Maybe. Or maybe we're here. Okay, so where do we go for therapeutics? Well, we've got a few places we can actually treat for therapeutics. We can treat looking at restricting the amount of methionine, aka diet. We can use betaine, and we can use potentially something that impacts CBS, and that's pyridoxine right now. Travere will talk a lot about the enzyme later today and some tomorrow, and so that helps us impact cystobetathionein synthase. CBS deficiency, we could also think about gene therapy as impacting that enzyme. But remember, we got to get out of the box one way or the other, okay? All right, so section X is really the monitoring section. And there's a lot of instructions in the guidelines of how do we look at people and what do we monitor. I'd like to point out that we don't have a lot of therapeutics outside what I just talked about. This monitoring is looking for complications. And so the guidelines are really focusing on what are the complications and then making sure everybody is replete in their folate, B12, D, and ferritin. Okay? So like this part, there's not a lot that the guidelines can address. And in fact, there's also some limited instructions about what you're supposed to do with some very important pieces. Women's health, women are fertile. Contraception, no estrogens, and pregnancy and delivery is a little bit underrepresented. Illness, what do I do? Regular treatment, do not let them get dehydrated. That's basically a summary. Surgery, fluids, feeds, normal meds. Travel, standard thrombosis recommendations, and outcomes and quality improvement or quality of life. That's basically the old guidelines. So what are we going to do with the newest set of guidelines? And that's why I'm like, write it on your cards. What do we need to do? Well, we need to do a little bit better in terms of our age-specific recommendations, because right now, whether you're 2 or whether you're 20 or whether you're 50, the recommendations for screening is exactly the same. And as we all know, as you get older, there's different things that happen in your life that are totally unrelated to CBS, but might be related to CBS. Is there any differences that we can do in diagnostics? Is there any new and exciting monitor changes? And is there different risks and complications as we get older? And what does the literature tell me about any of these things that's occurred in the last 9-10 years? We also really want to expand the adult care section. It was pretty underrepresented, and it was underrepresented in the individuals that were in the initial committee. And there's lots of questions about family planning and male fertility. And what do you do with pregnancy? There's some newer recommendations in terms of pregnancy, but there hasn't been a lot of good stuff. What's the hematologic risk as individuals get older? And what are some of the prevention recommendations? And how do you incorporate the adult recommendations that are used for standard care into these? And then there's not a lot about screening for intellectual risk and whether or not intellectual risk changes as individuals get older. And then older age recommendations. There's nothing about perimenopause. There's nothing really about osteoporosis other than you're at risk. And then there's some issues with therapies like insurance coverage. How do you make sure people are able to continue to take the diet that were started when they're a child? And then how do you balance this with age-related complications? So what do you do as individuals get older and have increased risk for hypertension, cholesterol problems, exercise, obesity? And then finally, probably the most important, how do you expand the patient voice in what we do as clinicians to help take care of all of you? How do you prioritize therapies and interventions? How do you bring somebody back to care who has not been in care for a little while, and what's the best order? How do you balance the burden to treat versus a patient's values and alternatives? And what phenotype do you all think is most important? Because I can say, oh, I'm really worried about clots. And you may say, I'm really worried I'm going to lose my memory, right? I'm really worried about the anxiety. I don't care about clots. I'm worried that I'm anxious when I get up in the morning. And so how do we balance that, and how do we best address it for you all? And then we are actually going to write some lay language summaries for patients and caregivers to make sure you understand what we're doing. We're also going to change diagnosis and screening. We're going to talk about newborn screening improvements and then clinical indications. Should there be an age that triggers an evaluation? The data has become much more clear about this. And then if you find with genetics only and somebody doesn't have, somebody hadn't been recognized, then what do you do? And the biggest player here is something called a variant of uncertain significance, which is a genetic difference different from the reference genome, but hasn't been described in other individuals who have CBS deficiency. And then other issues, we're going to talk about GI complications like pancreatic insufficiency. We're going to talk about the arthritis that people all tell me about and inflammation. We're going to focus a little bit on psychiatric disease, neurologic issues, and more information about diet. We also want to talk a little more specifically about anesthesia and emergent surgery. And then we have to address cancer. There is not an increased risk as far as we know from any of the cohorts, but we should probably at least touch on it. Also, there's going to be a section about the future, what research is needed, what's in the pipeline, and then what is for therapeutics and diagnostics. And then we're going to do questions and answers all together. And I tried to go fast because I know Eirini wants to talk a lot, because I know Eirini. This is my email, so if you don't want to fill out a card and hand me the card, please feel free to send me emails with any questions. Thank you all.
I hope I have more than 10 minutes. We want to have enough time for questions for you all. So I'll try to go fast as well. Thank you to the organizers for inviting me. It's a pleasure to be back. We always enjoy the family meetings the most. It is a village. It takes a village. We all work together to do what we do and improve therapeutics and improve the outcomes for the families and their children. So it was a real pleasure and an honor to be part of this revision of the guidelines. The first guidelines for cobalamin and methylation disorders were published in 2017 by this European group of experts, like similar to what Kim just presented for the classic homocystinurias. Yes. Yes, absolutely. Okay, great. No, please interrupt me. I'll try to be closer to the microphone. Perfect. So this, again, a nice group of experts got together back in 2017 and published the first guidelines for the cobalamin and methylation disorders. This was funded by the E-HOD, the SSIM, the cobalamin C group in Italy. They have a lot of patients with cobalamin C in Italy, and the HCU Network Australia. So this is now the new publication that was just hot off the press. It was just published this last month. This is for all of you it's open access. It can be printed, and please share with your clinics and your physicians, and hopefully it will help families get better reimbursement and insurance coverage for this concentrated hydroxycobalamin that we try now to recommend for kids with cobalamin C disorders. So this is free, available online. So we started this process back last year in a nice closed room, like Kim explained, in Rome. Martina Humer, Giorgio Olivieri, and Carlo Dionisivici were leading this effort, along with 24 experts in homocystinuria and cobalamin and methylation defects, basic researchers, neurologists, dietitians, clinicians that have seen many, many patients over the years, basic researchers, geneticists, really, and a patient representative. So similarly, we covered a lot of papers by the different manifestations of the disorders, the different subgroup, the different methylation disorders here. I took care of eye disease and neurocognitive development. We divided in different working groups. Every group worked on their special interest and expertise. Again, many, many papers, thousands of papers were reviewed and classified and distributed to the different groups. 306 were considered the most informative, the most detailed, and worth reviewing and including in the guidelines. So we had huge, big Excel sheets that we analyzed every paper, the evidence, the quality of the evaluations that they have, the number of the patients, if they have quantitative, neurocognitive, or eye assessments, if they had any bias, if they have a good control group. So we really detailed everything for every single paper, and then we graded it. We said, is this evidence low, moderate, or high? Many of the things are based on single case reports or small number of patients, so the evidence tends to be low or moderate. We don't have randomized controlled trials in rare disorders. That is a problem. Our evidence is based on expert opinion and low evidence, low quality studies. So in kind of as a summary, this is a guideline developed by experts, clinicians, scientists, and importantly, patient representatives. It is based on latest research and clinical experience, and is, of course, the aim is to improve diagnostic, treatment, and long-term outcomes, and have kind of a unified approach to the management of the patients across different clinics, because not every physician in every clinic has the time to read all the literature in that great length that we did. So what changed this last decade? What made the need to update those guidelines? Is that we have discovered new cobalamin disorders, rare defects that had to be added and updated in their different pathways. Now there is a more stronger emphasis in how to improve newborn screening. We have now prenatal carrier screening, better genetic testing that we can employ to diagnose children earlier and help families. And then there is a lot of discussion about doing newborn screening by genome sequencing. So this is all now included in these updated guidelines. And then we learned a lot over these last years because of better sequencing and genetic testing. We have a lot more information for the different misspellings in every patient's DNA in different cohorts in Asia, in India, in Europe, in America. So we have much better genotype-informed ways to help families with a prognosis and how to guide the treatment. There is a lot of growing evidence about higher doses of cobalamin earlier, especially in cobalamin C patients. Then we understand how to better monitor and test the progression of the eye disease. And then, of course, lifelong multidisciplinary care, educational, vision, psychosocial support for families. So those are the main updates in this current version of the guidelines. So how did this approach to management change over this last decade? As I said, again, diagnosis, we have earlier markers for newborn screening, rapid molecular confirmation, better genetics with prenatal carrier screening and exome sequencing. That's molecular genetics guided prognosis and individualized treatment that we can now do. Higher doses of cobalamin, we used to say 1 milligram a day, everyday injections and then titrate with age, increase slowly as the kids gained weight with time. Now we say we have to use more than 1 milligram a day, more than 0.3 milligram per kilogram per day. And we have now formulations of 1, 5, 25, 50 milligram per ml of cobalamin. We want now to start these higher concentrations right at diagnosis. So vision, we understand the importance of doing optical coherence tomography and really check the progression of the macular changes in the eyes more carefully to adjust dosing depending on that, or reduce the doses of cobalamin if this is not necessary. And then better multidisciplinary monitoring of all the elements of the disease to help the families and the quality of life. This is an updated figure from the paper describing the new disorders. So patients with cobalamin C sometimes had only one mutation found, not a second mutation, or they had no mutation in this gene that mainly causes cobalamin C deficiency. So those 3 disorders are transcription factors. One of them is X-linked. Those 2 are newer, very rare defects that also regulate this gene and cause silencing of the gene. So patients can have one mutation in MMA-CHC and another one in a different gene that causes silencing of the MMA-CHC and present very much like cobalamin C patients. And then there is another newer disorder for the folate cycle that causes megaloblastic anemia and severe immunodeficiency. So those were added to our pathway. I will not spend a lot of time in the pathways because my colleagues have covered this, the bifurcation step where B12 is important for those 2 enzymes, the methylmalonyl CoA mutase in the mitochondria and the methionine synthase in the cytoplasm. The defects that are early in the pathway cause combined high MMA, high homocysteine, and low methionine. This is a big difference in this group of disorders with a classic homocystinuria. Our group of disorders have very low methionine, and we try to increase methionine with the B12 and our treatments and not do dietary restrictions. So there's a big difference with our classic homocystinuria patients. So those are the combined defects, and we pick the high MMA through newborn screening with the elevated C3. So those disorders can be picked up at newborn screening, although some are still missed. We use better ratios, high C3 over C2 or methionine to phenylalanine ratio to pick up more children through the classic newborn screening. A second tier is necessary to confirm the high homocysteine and MMA, and all these disorders have normal serum B12. Now, in the isolated homocystinuria, this methionine synthase only pathway, the lower part here of the pathway that affects methionine synthesis, and those are the cobalamin E, G, and MTHFR. Those are not picked up at newborn screening because they don't have elevated MMA. Sorry. So we have to use homocysteine as a first tier or maybe genetic screening to pick up these children earlier. I like this graphic in the toolkit by the HCU network. They do a fantastic work, and I encourage everyone to download their materials. They have the isolated homocystinuria disorders, isolated MMA, and then the combined defects here to help visualize these pathways better. Again, in the guidelines, we go through all the manifestations and the different complications that affect different systems with remethylation defects. Very early on, already in utero, during pregnancy, the children can be small for gestational age, have a slower head growth, can be born with eye changes or heart defects. Then later on, as babies, we have this rapidly progressing pulsar maculopathy, especially in cobalamin C. Children cannot focus, they have nystagmus, this wiggly motion of the eyes. They have hypotonia, delays, seizures, hydrocephalus. They have macrocytic anemia, failure to thrive, hemolytic uremic syndrome. Later on, they can present again with more psychiatric symptoms, intellectual impairments, thrombotic events, psychosis, gait issues, fatty liver, and other system involvement. I mentioned that we have now much more information on the genotypes, the DNA misspellings that cause remethylation defects, and then certain mutations are known to cause more severe disease versus others that cause milder disease. This is very important for your doctors to guide their intensity of the treatment for lifelong. So the C271 Dupay variant is a known 40% of alleles in the European ancestry individuals. That is a well-known variant that we know causes classic early onset severe disease with progression of the eye findings. So for the treatment, we use high-dose hydroxycobalamin. It bypasses those blocks early in the pathway and pushes these two enzymes effectively to lower MMA, lower homocysteine, and increase methionine. This works great for the cobalamin C and those early defects. It doesn't work as well for the isolated methionine synthase defect. We need to use more betaine for these patients to push methionine synthesis through a different enzyme, the betaine homocysteine methyltransferase. So we use cobalamin and betaine to increase methionine synthesis. We also use folinic acid to help with the folate cycle. And then again, we have this diagnostic pathway. You have very high homocysteine, and depending on whether you have low methionine and high MMA, we divide the patients to combined defects versus isolated defects, and then in the combined, we maximize the hydroxycobalamin very early and add betaine. We depend more on betaine for the isolated homocystinurias and MDHFR. For all these diseases, we don't need protein restriction. So because they had high MMA originally, we were reducing the protein for these patients and used special formulas that had no methionine. That was not the correct way to manage these diseases. So now we really emphasize that we should not use the special formulas. No protein restriction is required. Again, we avoid nitrous oxide anesthesia, and cyanocobalamin is another form of cobalamin that, especially for cobalamin C, it cannot be processed and it's the wrong cobalamin to use. So hydroxycobalamin is the injectable cobalamin that our patients need. Sorry. So what happened? Why the change? We really see an impressive outcome shift. The standard doses were leading to cognitive impairment and delays for the patients. But high-dose hydroxycobalamin started early, the first months of life, really. We now start seeing near normal IQ and stable outcome in the patients, which is really very, very encouraging. And the timing matters. So every week does count. There was a significant correlation that is described in the guidelines between the age of start of treatment and the final IQ scores. So early detection, early diagnosis, and starting cobalamin every day at diagnosis is critical. And now what we were not expecting, because all our classical thinking of this disorder said that despite newborn screening and despite daily dosing, we could still see this progression of the maculopathy. It was resistant to our therapy. 80% of early onset cobalamin C patients had this progression of the bullseye macular changes before 1 year of age with a standard dosing. But now with this intensified regimen, we have seen a small number of patients that have no signs of maculopathy up to 8 years old, which is incredible. So despite that, all this is based on small number of patients and the evidence is low. So the guidelines agree to say that we need to use high doses starting in infancy, more than 0.35 milligram per kilogram per day. So that is going to 5 milligram or 10 milligram right in infants, young babies, to drive the homocysteine to the lowest available concentration that we can and have methionine in the normal range, high normal range. This is summarized here in different tables in the paper. Again, those are the main reports. Very small number of patients. You see 1 patient, 5 or 6 patients in each report, different doses of cobalamin. I summarized it here just to show you the different levels of what cobalamin dosing, how we think about cobalamin dosing currently. Our traditional approach was 1 milligram every day. If you count a baby that is 3 kilos, 1 milligram every day is about 0.3 milligram per kilogram per day. So we started with 1 milligram every day, and then as the kids get older, that was much, much less than 0.3. And it had no effect on the vision or even in the cognitive outcomes. Now, this paper by Olivieri et al. Is a very nice Italian cohort. All the kids were picked up at newborn screening and were treated with about 1 milligram per kilogram per day. Those are the concentrations that they have available in Europe, 5 milligram per ml or 10 milligram per ml. So the children were started early with these higher doses, and they all had much better cognitive outcomes, but all the children had severe maculopathy. So the cognition improved, but not the eye changes. Kakpura is a single report, but it was very informative because with starting at newborn screening at 2 milligram per kilogram per day, so going to 10 and 15 and 25 milligram the first couple of years of life, this patient has 271 2P homozygous, severe mutations, and is normal cognition and normal vision. At the paper, it was about 19 months. This case is now 6-7 years old and still has normal vision. Now, the SCALE report is the European report where they prepared cobalamin at 50 milligram per ml and used these very high concentrations in the cases of 3 to 7 milligram per kilogram per day, because that is, we learned from this paper that this is how much you need to normalize homocysteine. So trying to keep the metabolites normal throughout this after diagnosis requires extreme numbers of hydroxycobalamin, up to 150 milligram a day. So they use a port and several injections every day to reach that very high level of cobalamin administration. And they have better cognitive outcomes and again, very minimal changes in the eyes. But again, it was very hard to determine a specific dose. So the guidelines say, we know we need to use more than this line to protect the eyes, but exactly how much is really hard to tell with the existing evidence. This is what the maculopathy of cobalamin C disease looks like. This is a normal, this is the retina, this is a photograph of the back of your eye. This is the optic nerve, and this is the macular, which is the region that is necessary for central vision. And in cobalamin C, you have this bullseye maculopathy, this atrophy here and hyperpigmentation that looks like a bullseye. This starts very early, already the first 3 or 4 months, and it progresses until in your 20s. The macula is very affected and the rest of the retina. Our cohort here at the NIH, we have seen about 100 patients with cobalamin C, so we have really characterized their vision and the progression of the maculopathy in many patients, really very well over 20 years. So every parent is like, what is the right dose for my child? Of course, so we now say, if we can have a diagnosis in utero, we use B12 treatment in the pregnant mother, 10 milligrams 3 times a week or 5 milligrams a day. We have patients treated like that that are now 3 or 4 years old and have normal outcome, no sign of cobalamin C. If the diagnosis is made by newborn screening, we start at 2 milligrams per kilogram per day at diagnosis and then increase and examine the eyes regularly to make sure and adjust the dose. Now, if the child is older, really our limitation is about the formulations of cobalamin. The maximum is 50 milligram per ml. So we stay at that high dose and we don't see progression of the macular at these ranges. So maybe this 50 milligram a day is enough for these older patients until maybe they go through puberty or they grow older. We have to watch again and examine the eyes and see if we need to go to 2 injections a day or find a way to administer these high doses of cobalamin lifelong. And then late onset cobalamin C, again, based on your mutations, you can use much lower doses, are very effective. We all discuss with our families, and oftentimes my nurses and nurse practitioner discusses in detail what is the best needle and length of needle to use. Subcutaneous injections work fine. You don't need the long 1-inch needles to go in the muscle, so 5/8 or half an inch needle is fine. And then the gauges, you can use 28, 27 is smaller needles, easier to inject every day subcutaneously than intramuscularly. And for that SCALE, the Belgian report, they use these ports to give 50, 100, or 150 milligram a day. Those are devices used for diabetics that need multiple shots a day. They don't go very deep in the subcutaneous area, so sometimes they leave more bruising or cause local irritation, but those are ways to administer more cobalamin. For monitoring, we kind of covered that. I don't need to go back to multi-system monitoring. And really just to say this hopeful message that we have seen in the 20 years of our study, we have seen children from severe intellectual impairment, seizures, and vision loss early in life to children that are now have normal vision, a much improved IQ. Those are my colleagues, and please stop at their posters. Both Jen and Susan and Carol will be at the posters later today to discuss our natural history findings. So, and with that, we will.
Thank you, Dr. Chapman and Manoli. We will now have a question and answer session for all three of the speakers. If anybody has a question they would like to ask, please come up to the microphone up here. Yes.
Hi, good morning. Thank you both for that very informative presentation. My question has to do with the betaine. You talked a lot about for cobalamin C specifically, the need to increase the concentration in the dose. There wasn't a lot of discussion on the betaine, so I was wondering, what are the guidelines for that as far as dosage? And
Cobalamin C specifically?
yes, Thank you.
Do you want to come up here and talk? We'll just stand here and go downstairs.
I didn't expand more on betaine because it hasn't changed. We still say 100 to 250 milligram per kilogram for betaine. We split it into 3 or 4 doses, so it's better absorbed. It's with a very high concentration cobalamin, we see much lower homocystins. So sometimes not as much betaine is necessary because when the homocystin is in the 20 or 15 or 17, betaine won't work very well to make more methionine. So with better diet and a lot of cobalamin, we don't need as much betaine, but we like patients to start betaine because it tastes really bad. It's much harder to start later in life. So we have even young infants on a lower dose of betaine as maintenance so that when they outgrow this 20 milligram or 30 milligram per day, and we start seeing the homocystins increase when they're older, as teenagers or adults, we depend more on the betaine at that stage.
Thank you very much.
So the betaine dosing is actually based on a study done out of the UK that looked at dosing 50 milligrams per kilo, 100 milligrams per kilo, 150 milligrams per kilo, 200 milligrams per kilo, 250 milligrams per kilo. And what happens is at higher betaine doses in CBS deficiency, we think in cobalamin C, you actually plateau in your response. And so there's also some discussion about whether you become less responsive over time if we've given you huge doses of betaine over time. And so oftentimes the goal is to be in that sweet spot where the dose is kind of at that curve, not where you're at the plateau. Because the higher you go doesn't necessarily mean you get the same outcomes. But it's based on a CBS study done in the UK.
Great. Thank you.
Hi. So my son is 10 years old and has classical HCU, and he's now had 4 broken bones. I know there are some, potential bone susceptibility issues. We can't seem to land on anything with our provider. I've asked about the bone density scan, but we've kind of just heard that, his levels are generally controlled. There shouldn't necessarily be any, risk, I guess, additionally there. But is there something we can do, give him, supplement other, I can't put him in a bubble. He's 10 years old, plays sports and wants to jump on trampolines. But is there something we can give him supplement-wise, or what do you recommend?
So understanding about the osteoporosis that we see in classical CBS is just starting, honestly. And it's a combination of things. It's not just your homocysteine. It's probably some of the cross-linking that we're seeing, that if you're missing cysteine is a problem. Unfortunately, we don't have a specific kind of thing. So right now, the guidelines are all going to lean in to make sure he's vitamin D replete. And there's an inflammation that goes along with the homocystiniurias that we don't quite understand. We're just starting to understand. And increased levels of inflammation makes you more susceptible to having osteoporosis. There's also probably a disadvantage when we're using diet in that it's an acidotic, so it's acid filled in terms of any type of protein restriction that we do. So it becomes this balance between how do I treat someone so they don't have thrombotic risk versus this osteoporosis. We see the osteoporosis in other metabolic diseases that are on diet. So it's probably not just the kind of inflammation or the acidic diets that we're doing. But the recommendation is make sure your calcium and vitamin D replete because you can become deficient on a specialized diet. I wish I could tell you that there's growing evidence in how to treat the osteoporosis. There isn't. Nobody's actually looking at it very specifically in terms of new therapeutics. So currently we're using standard of care. There's a big debate about whether or not we start using things like palmidronate in a population that has an increased bone density. That's a drug we don't typically use in children that are growing, because of the other risks that go along with it. So the bisphosphonates, there's some discussion about whether you use it or not. There's some risks that go along with that. And so it's unclear whether that risk will overcome the risk of the underlying things. Did that help?
Well,
I
sure.
know it didn't
Yeah,
provide
no,
you an answer.
It helps, but I guess basically, yeah, his nutrition labs always come back normal. It doesn't show deficiency in calcium or vitamin D.
Yep.
So then it doesn't make sense to then supplement, right?
Correct.
Okay. We have not. So I've asked the provider if we should get a bone density scan, and he just steers us away from that.
So it comes to norms. So the recommendation is actually to get a bone density scan around 10 and then potentially every 5 years after. The big argument that if you sit in the locked room with a bunch of the experts is what happens when we find low bone density if we can't treat vitamin D and calcium deficiency because we don't have an underlying good therapeutic for
makes
it.
sense.
Yeah, right? So like if you look and you find it, how do I provide that service to you if I don't have something?
And that may make me want to bubble wrap him more, and I don't want to do that. So
Yeah, let's not bubble wrap him because there is very clear data that there's osteoporosis by late childhood on a series of studies done out of Europe.
thank you.
No.
My name is Ruby. Hi, I'm 19. I have classical homocystinuria.
Okay.
And I've been taught from a very young age the importance of, I take the HCU coolers
Yeah.
and the betaine.
Yeah.
When I was in the pediatric hospital, I was prescribed with folic acid. However, it hasn't been mentioned since I've transitioned to the adult care.
Mhm.
And with the betaine that I take and the coolers, and then of course the trial medication that I'm on, I understand the importance of each of those three separately, but I don't understand how folic acid is important or why it's important, and therefore it's very hard for me to remember to take it. So I was wondering if you could just explain that a little bit.
Okay. So Dr. Thompson put up that picture, right? With the two big circles,
Yeah.
right? I kind of ignore the second circle when I put everybody in a box. But the second circle is folate and B12. So that's how you make methylation groups. So you convert homocysteine to methionine by adding a methyl group.
Yeah.
And you're using that. Individuals with classic homocystinuria and with the remethylation disorders have B12 or have a folate sink where they suck all their folate in and it doesn't get used very effectively, right? So what we're doing when we do folate and B12 supplementation is we're trying to overcome the fact you're sucking it all in and you can't use it as a methyl group or as a methyl donor. And so that's why we do kind of folate supplementation. You're also a young female that may someday want to have children.
Yeah.
And so we would expect you to require folate to help prevent having open spinal cords kinds of thing. So that would be the reason why folate is really important to you, not just because you have CBS, but also because you may someday want to have kids, right? But that's why we tell you to be B12 and folate. Sometimes it's easier to just take folate and B12 by mouth if you have CBS deficiency than worrying about what the numbers are. In addition, I can't necessarily tell that you're B12 deficient the best way if I can't look at those markers, because one of the markers is an elevated total homocysteine. Answered your question? All right, cool.
Hi, good afternoon. Thank you so much for this information that you're providing to us. But I have a question, and my question that I have is I wanted to know how is anemia deeply intertwined with homocystinurias? How is yes?
Okay.
Because I'm an anemia patient.
Yeah.
So I just wanted to know, like,
Yeah.
how is that
So-
intertwined and connected together, and what are the and are the symptoms the same or similar?
Okay, so anemia just is having a low red blood count, okay? So your hemoglobin, your hematocrit, and your red blood cells and we need B12 and folate to build our red blood cells, all right? So if you don't have B12 and folate, you can't build red blood cells. If you do not have enough B12 or folate, your red blood cells get really big. Okay, they're macrocytic anemia. If you don't have folate, they get really small. All right, and that's because you need it to build the structure so you can hold the oxygen. So when we're talking about the homocystinurias across the board, because there's either a cobalamin B12 processing problem, a folate processing problem, or you're sinking all your folate in B12 because you've got classic CBS deficiency. Either way, you don't have enough to help build you that structure that you need to make red blood cells. So across all of our disorders, we can see pancytopenia, that's low blood cell counts of all. We can see anemias, that's low blood cells, big cells, little cells, across all of the disorders. But part of that is because we're stealing it and we're holding on to it because that whole pathway doesn't work. Does that make sense?
Okay, thank you for the clarification.
No
Yes.
problem. Make sense to everybody? Okay, cool.
We have time for one more.
I'm an adult with classical HCU, and you had briefly just discussed about the arthritis and the inflammation.
Yeah.
And I have been experiencing a lot of inflammation to where it's causing my D dimer to go up substantially.
Yep.
And so it's a little hard to decipher, is this a PE? Is this a clot? What is this? Can you speak a little more about what you know about that or what you're recommending for these inflammations?
So we don't know a lot.
Okay.
I'll tell you. It's like the cutting edge.
Uh-huh.
So one of the big discussions is starting out by recognizing that we see a lot of arthritis. And D-dimer is an acute phase reactant as well.
Mhm.
And so anytime you have inflammation, you'll see that go up. You'll see CRP go up. You'll see SED rate go up. And honestly, we don't know a lot about it. We do know it exists. We know it's getting reported from our family groups and but docs haven't paid that much attention to it.
Well, have you seen a correlation between autoimmune disorders and HCU or HCU contributing to these autoimmune disorders, which is making the D dimers go up?
We don't have data that supports that. We do have some case reports that are just starting with some autoimmune disease, but it's kind of your doc's fault because we don't publish all of these kinds of things. I also wear a hat where I'm a journal editor, and I don't see it come across my desk, even though we stand around and we talk about it, right? But it doesn't, there hasn't been a lot of reports of seeing it. The biggest cohort is actually the E-HOD cohort. There's about 350 CBS deficiency patients going all the way from neonatal up to adulthood. And they don't actually even ask the question about does this patient have, or they don't ask the question specifically, are we seeing autoimmune disease? Have I taken care of CBS patients that have autoimmune disease, like rheumatoid arthritis, like Crohn's disease? Yeah. There's 2 case reports about Crohn's disease and autoimmune and inflammatory bowel disease out in the literature. There's so little information about arthritis out in the literature right now. So the answer is we don't know the answer to that question. So please fill out the card and we'll try to make sure we stick it at least in the
follow
future
me.
aims. Huh?
I said you can follow my case.
Yeah.
You
So
know.
like that, but like we have to get it in the literature to be able to like say, this is something we need to ask across the whole cohort.
Okay. Thank you.
Thus, I'm going to do the ad for Rare X, people. Rare X. All right.
So one of the things that helps in the guideline development is, yeah, in the guideline development, we can't publish on things that there's not case reports, that there's not publications for. And we all have the power, and I will preach this to the cows come home, because I'm sure you guys have heard this if you've heard me talk about research. Encourage your doctors to write up your case reports about the things that you're experiencing, because if it's not out there, they don't know the problem exists. They can't know a problem exists if no one's reporting it. So encourage your doctors and fill out those Rare X surveys, participate in natural histories. There's a lot of opportunities. We'll have a session on that later this afternoon. But encourage your doctors, hound them, nag them. They'll eventually follow through if you're persistent enough. They are busy. Please be kind. Yes, but that's how we start to develop and get more things into the guidelines. You can't have guidelines without sound science, and we have to start there. And so,
Danae, I have a question for you. Do you now know how hard it is to make the sausage?
oh, yes. So everyone's like, why can't this be in the guidelines? And I'm like, there's no data to support it. There's not even case studies. Like,
I have her locked in our CBS guidelines, just so you know.
It's
She's stuck
heartbreaking.
on the meetings.
yes, it's heartbreaking because I hear things, you hear things, the doctors hear things, they're not published. Get your doctors to participate. We need them. They're a missing link in all this. So I will let Holly take over so you guys can have your break.